today.
Hold on, let me get my voice corrected here.
Yeah. Hi everyone. Today is very nice day outside. Raza, did you see the weather here in Lansing? It's beautiful. I think we should play soccer today.
So you were saying we should take it easy today on them, huh?
Yeah. So today we will have Raza with us and go over some of the agenda. So basically, the first section will be presented by Dr. Raza Haq, the cognitive capacity and the assessment of that. Then we will talk about some articles and we'll also touch on some heat prognosis, how we can use this tool. So when Raza is ready, you can start. I think you are working on your technology.
Okay, I am ready. If you all are.
So we are ready. Yeah, this is recorded, so some fellows will join later. So
how are we expecting? How many people?
So usually about 25 will be present.
Okay.
But
we give them a few minutes.
I think we can start and they can look at the recording.
Okay, so it needs to be interactive. So we need to have responses from whoever is participating, because it's more like a conversation we are going to have. So I need some volunteers and I need people to respond to the questions so that the conversation can move along. Is that okay with everyone?
Sounds good. You want them to text or to talk over? Mike.
Always good to have someone talk to, and you can text as well, but I think since it's interactive, someone has to talk beside me too.
Sounds good. So hi everyone. So Dr. Raza will start the discussion and it's going to be like basically a conversation. So feel free to ask question, share your thought, and we will share the information together. Thank you.
Great.
Go ahead. Raza.
Thank you for turning on your camera. So it's interactive. And let's see. So folks, Nadir asked me to give a presentation on cognitive capacity assessment. So when we are talking about cognitive capacity, I believe you all are physicians, right? So you do have to and have been in past come in a situation where we were asked to ask someone's cognitive capacity, which means are they able to think for themselves, right? Make judgments, the decisions which are okay, particularly if someone has a psych background. So cognitive capacity is really the ability to make decisions. Have you done anyone has done any cognitive capacity? No, not yet. If you hang out with Nadir, you might have done it.
No, not yet. Some practice outside the United States, in Ireland and some in the Gulf. Any one of you guys did evaluation overseas? Cognitive evaluation? No.
Okay. All right. Well, let's just start with that. I need a volunteer.
So Hiba raised her hand, invisible hand, but Hiba is ready.
Okay, no problem. I'm ready.
Okay. All right. So you're the volunteer. And what is your name?
Because my kids. So my name is Hiba, and yeah.
Okay. So Hiba, how you've been doing today?
I'm great. I'm great. I'm doing fine, actually.
Daddy said yes, TV.
Great. Great. I can hear.
TV.
I can hear you have a child, right?
Daddy said yes, TV. Oh, can you get the remote?
Go to daddy. I'm sorry
That's
about this.
okay. We all have children of different ages, so
Mhm.
that's no problem.
Mm.
How long you um, have this child? How old is your child?
She's 5.5.
5.5.
Yeah.
Okay. And so, and how long you have been at the current address that you are at?
What? Can you repeat
Your
this?
address, home address?
Oh, I'm living in Colorado.
Okay. What is your home address?
My home address is
Don't give me your social security, just home address.
yeah, the in East Powers Drive.
Great. And what's the number of the unit or house?
23845.
All
Yeah.
right. And you know the zip code?
Yes, is 80016.
80016. So is it first floor, second floor?
It's in house.
Okay. Okay. It's a house. So do you walk sometime?
Yes, I do. I do walk
You
all.
do walk. Okay. Would you like to walk in woods sometime?
In wood?
Woods, yeah. You know, wooded area, trees.
Oh, wooded area? No, actually, no.
So let us walk you to a wooded area
Mm-hmm.
today.
Mm-hmm.
This is an imaginary situation.
Mm-hmm.
And you, Hiba, are walking in a wooded area.
Mm-hmm.
As you were walking, you forgot where you were for a while because it was a really great walk. And then you heard a gunshot. And that gunshot, and someone said something that sounded like Hiba. And you said, oh. So tell me, what would you do now?
I will run.
You run, okay. Which way would you run? In the cardinal sign, east, west, north, south? Which way would you run?
I will run from opposite to the opposite
Okay.
direction
So
of
you
the
would run the direction opposite to where you thought the
yeah.
firecracker gunshot, who knows what, right? So
Yes.
you're doing it. Okay, you started running. And I say you ran and about running for 2-3 minutes. You came at the end of the road where you could only go left or right.
Mm-hmm.
You can't go straight. It's end of the road. It's a bifurcation in the trail. And on your left, you saw seemed like a tiger about 1,000 feet away from you and looks very, very hungry and emaciated. You said, oh, you look on your left and you are seeing you have an elephant who is looking crazy and uprooting a tree trunk, look like a drunk elephant.
Mm-hmm.
1,000 feet, one left and one right. What would you do now?
I will go right toward the elephant. At least I can squeeze under it because his motion will be heavy, but the tiger will be
Okay.
very fast, so I can sneak around.
Great. So the reason you're going towards the elephant are that it's an omnivorous,
Mm-hmm.
right? Actually herbivorous. It doesn't eat anything but grass, right?
Mm-hmm.
And why would you not go to a tiger?
Because if I go to the tiger and he's hungry, even if I'm trying to run from him, he's faster than me and he will catch me. No way.
Okay. Once he captures you, what he's going to do with you?
He's gonna eat me. I'm
Yeah,
gonna be
exactly. You're a steak for him, right?
yeah.
So the decisions that you're making in your head is, okay, this kid is herbivorous. This kid is carnivorous. He is faster and is slower. This is bigger, is more nimble. You made all those decisions, right?
Mhm,
Okay,
yeah.
tell me what other choices you have beside these two.
To go back where the gun shot and face it.
Face it. Okay. So when you go back, what would you expect?
I may not. It may be just an exaggeration for me. Could be an option.
Okay.
I just imagining that's my name called, and in fact, maybe just I'm putting myself in a threatening mood, or it is real. And if it's a gunshot, it would be a human. So I would communicate with and ask like, what's wrong? What do you want from me? And try to
Okay.
see a solution.
Okay, that's great. That is great. So in other words, you were weighing all your options and making this. So it's not about what option you choose. It's about how did you come to that conclusion of making choice of which one you are going to make. So and when I throw this out for a student and resident and other learners, some people would go back and face the other, the threat. Other are going to try to tame the elephant or hide in a tree. So there's a lot of things you could do. But each time you are making this decision, it is based on your logic and reasoning for the threat assessment. An immediate threat that you face, you are making decisions on the run to try to protect yourself, knowing that each decision that you make, for example, choosing the elephant, this is not just because you like elephant, right? You just because it's big, you have a chance, it's slower, it doesn't eat you, you have a chance, right? So you know the consequences of the decision that you made, and you could make the decision towards going to the tiger at this using the same reasoning, right? So the things that we learn from you, first of all, let me declare you that you have the cognitive capacity intact at this point, Hiba. Right? So I know you were very confident, but yes, you have intact cognitive capacity. Let's get back to now the legal terms around surrounding it. So there are two things that we generally face when we see someone say have a psychiatric illness who is a threat to himself or perceived as someone with a knife who wants to cut his throat and kill himself, or someone who overdosed on a medication. So when we see them, we as physicians or healthcare provider, our job is to see they are
the cognitive capacity.
Cognitive capacity and not the competency. So there are two terms. The system takes a person and asks the expert and say, hey, you doctor? Yeah, I'm doctor. Hey, could you do the cognitive capacity? So you will perform the cognitive capacity on the person. And then based on that cognitive capacity, a court of law or a judge will decide their competency. So there are two different terms. Capacity is the cognitive ability, brain ability that we judge. And the decision to declare someone incompetent is not our job. So first thing is, that's what we do. So a lot of time it's interchangeably used. And it has a very common stance in cases of psychiatric illness. If you send someone for admission, they will be kept there for 24 hours, and within 24 to 36 that you need to what you call corpus habeas in the language of law, which means you cannot hold someone against their will. So someone say, I got suicidal and I have a gun in my hand, and paramedics came, they took me to the hospital. At the hospital, the emergency physician is going to quickly perform my capacity and say, oh my God, he's threat to himself. Now let's see if he's capable of making this decision for himself for now or not. And then he will activate the social service system, and which will activate the legal system. And if I admit him on hold, I get held in the ER against my will. So I'm saying, I'm not going to kill myself. But how do you know, right?
Yeah.
So that's why you perform this kind of assessment. And to hold me, I need a legal judge to say yes. And that is where you, as physician, would perform this capacity. So that can go to the due process for declaring someone competent or incompetent. Many ways of doing it. And I just gave you a very funny way of doing it, right? But generally, this is not for everyone. it is good for someone who has a mild cognitive impairment. I walk into a room, meet this person who has dementia. He wants to go home, but he's in a nursing home. Family knows that he can't. He has issues with memory. He has lost his keys, did not turn off the stove, almost got the house on fire. But he feels that, no, I can't. And I walk into this room and I meet this guy. I'm saying, okay, how can I do that? So a lot of people will do mini mental status exam. So as soon as I started asking your home address, you were like, well, why is he asking my home address? Though you are not in a hospital, you are not demented, you are miles and miles away from me, right? But it becomes personal information, right? Asking someone, when were you born? What's your date of birth? And you say, what is he doing? Maybe he's gonna ask my social security. What the heck, right? So people, when they are in hospital or healthcare setting, they are already nervous. And if they already have cognitive impairment, they are even more nervous and paranoid. So to perform cognitive capacity using a standardized tool like mini mental status exam and then MOCA and different ways of, so there is no one good way of doing it as long as you approach it skillfully. So if I could sit down next to him and say, hey, what you doing, Max? And Max started talking and said, hey, so I see that you hunt, and I could kind of relate with him. I see something that's reading. I'm gonna read this book. Oh, it's great. And then starting a conversation. Idea to get the C's out of them. What are C's? Does this person, does he understand that he has choice? The choices that he has. Other C, does he know what are the consequences of the choices that he can make? So that's what capacity is, making sure that people understand they have choices and they know they have the choices, they have the liberty to make those choices, but knowing what are the consequences of that choice. These are the 3 C's that you look at. Question at this point before we go further?
So is this mean that they have the reasoning for their actions?
Yes.
Okay, another
So
meaning.
cognitive capacity means I have all my brain operations functional. So when we do, and it will sound a bit interesting, but look at this, the way the brain works for us in the functional part. So let me ask you all a question. Do you think a cat can do mathematics?
It's
Anyone? There are 21 participants, minus me and Nadir. What do you think, guys?
I think cat can make mathematics.
Okay. Are you sure?
Yes, but because if they are in a very high place, I feel they are hesitated to jump.
Yeah.
So they make like estimation, I think.
I am proud of you. I am proud of you. So
Thank
yes,
you.
length, breadth, height, and volume. So if when we were kids, and don't judge me on that, me and my 3 brothers, we had cat and we did snip the cat's mustache and whiskers. And guess what she was getting into? She could not get through the hole from which she used to run, because that's how she measures, the cat measures. So they do math. They have rudimentary mathematical operations, but they don't sit down with a book. That's just, you have to be so stupid as a human being to require a pen and pencil to do that kind of work. God has given them the strength already. They can do their math, right? So they're simple arithmetic operations, and then the brain work for more logic engines, the deductive logic, inductive logic, deducing the fact that 2 animals, and then one is carnivorous, other is omnivorous, or other is herbivorous. You're kind of bundling that information, and that's called the deductive and inductive logic. Once you do that, then you develop your integration, you apply integration, the analyzing that information, and So most of us, even if you were weak in math like me, we should feel proud that we apply all mathematical operations in our head, just like the cat does without the pencil, right? So we use integration, we use optimization, and then we use modeling. Modeling is where I'm saying, okay, I imagine myself going back to that guy with maybe having a gun. So what you're doing is using deductive inductive logic to get to the point where you are actually making that decision on modeling basis, which is the highest mathematical operation that we can perform as a Homo sapiens sapien. So what we are doing in cognitive capacity is really asking the person, do they understand what they are asking, they're being asked of them? Are they optimizing it? They may be optimizing wrong, but do they know what they are doing? So and do they know what their choices would mean? So let's bring it back to a very common situation. A common situation is you walk into a room, and now I'm going to ask everyone to respond to that. You walk into a room, you see a patient who's bilateral amputee below knee, and you want to do his capacity. So capacity has three forms. One is the ability to make decisions pertinent to their health and well-being, and then the capability, cognitive capacity to make decisions regarding their finances. So there are two parts of it. We generally deal with the ability to make decisions pertinent to their health matters. So this is a bilateral amputee. Walk in there with 40-year-old, has a history of mental illness in the past and maybe not, did have a stroke, which is minor. You walk in and you want to assess if they have the cognitive capacity. What would be a good question to ask without asking him? You already know the name, you already know date of birth, right? So decide the general data that is already in the chart. What would be one or two leading helpful question that would give you help? Anybody want to give it a try?
Ask him about how he come to the hospital.
Okay, very good. Very good. Anyone else? So you could open and say, no, Mr. Smith, I'm really, my name is blah, 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 and heard that you were in the hospital and I am going to be a physician. Tell me, how did you get here? And that way you can get an open-ended question, things coming through. Or you could sometimes just don't have to just sit down having a conversation of two people. So let me give it a shot. So I'll walk in, I'll say, hey, Mr. Smith, how you been? And if he doesn't ask me who I am, he could see if I have a coat and think he's a doctor. He would or he wouldn't ask me. That's fine. I'll sit down next to him, introduce myself, and saying, so what's the plan? It's an open-ended question. So then if he knows that he is sick and he is in the hospital or in a nursing home, he would know what decisions to make, right? He'll give you this story. And if that story is already giving you information that you are going to ask him through his date of birth and home address and all that, without making him nervous, right? So I can ask him, I heard in the hospital, there are cases that has been fire. What would you do if there is fire in this room, in your room? I hope not, but what would you do? So what do you think that response would be, right? One guy would say, oh, I'm gonna just get out of the room and run. And you're seeing this person is bilateral amputee. And you said, okay, tell me walk me through step by step exactly what you're gonna do. Oh, I'm gonna call my daughter, call my mom. I'm gonna break the window. How? Walk me through that. If they can't walk you through, that is understandable, right? So this is exactly what you are doing, what I was trying to do with you, Hiba. That's the same thing. It's a different scenario. You were able to make those judgments, understand the choices and the consequences of each choice through your logic and reasoning. And in this case, he is making choices, but he doesn't know that he can't walk without that, right? So you dig in a little bit more. Some would say, hey, I am going to call the nurse and try to roll out of the bed. In other words, you could get hurt, you know that? I said, I know, but it's better than being dead. I would finish my interview right there. Said, okay, well, I'm glad that you are aware of. So now this person is aware of the consequences of the decision, the choices that he has in case of health and safety. And I'm gonna, in the chart, I will write that I saw Mr. Smith for a cognitive capacity on the request of nursing staff or social worker or whoever. At the time of my assessment, I found Mr. Smith to have the cognitive capacity to make decisions pertinent to his health and safety. That is why we would say the key points are at the time of this assessment. Because if a person who also has, say, multiple diseases, you can get an infection because he's a diabetic, he got a pneumonia now, you can get delirious and you can get confused. That can change. So that is why when we perform cognitive capacity, we want to make sure that there is a time stamp on it. That at the time of my assessment, I found him to be cognitively not intact or lacking the cognitive capacity to understand the choices in the matter of his health and the decisions that he make on the basis of those choices. I found him lacking that cognitive capacity, not competency, right? Okay, questions?
So far, any questions as far as the process?
No?
Excuse me, everyone. I have one question regarding
Yes, please.
this question. When I ask the patient, do I have a standard score for their answer? Like this question, like logical reasoning for their action. How I can differentiate if there is any grade or score or just right or wrong answer?
So the best answer to your question is you can yourself go through this exercise, but Hiba went. So what we are looking at, there is no standardized process for it. That's why we are talking. If there was, you could take a performa and mark it, right? That's not it, fluid. That's unfortunately. So, but a standardized procedure, if you want to apply on cognitive capacity, you can perform mini mental status exam, which means looking at the alertness, looking at the recognition of 3 words, able to repeat them and spell the word backwards, step like that. You can perform those testing. That's not wrong. You are more than welcome to do that. But again, the basis of the cognitive, this testing does not really judge the capacity. It requires you to be able to reason. Why? Because you can choose to look, hear 3 words and able to recall them in 1 minute, but it doesn't stresses the actual situation where capacity is required. It's just taking a test, right? So in a situation where people may have mild dementia, they cannot do serial subtraction. So it's good if you want to do the full battery testing, people do it. It's okay to do it. It's one way to do it. Then you can say that this person, in my opinion, the same person, let's say, change the scenario and make this patient, Mr. Smith, 80-year-old with a history of dementia. on the chart. You go in and you talk to him. And if I ask the same question, and if he's amputee and I ask the same question, and he says, I'm going to roll and do that, does he have the capacity just because he has history of dementia? What do you think? Mr. Smith now is an 80-year-old man with both feet amputated or legs amputated below knee. And we ask the same question and say, Mr. Smith, what is there is in case if there is a fire? And he says, I'm going to roll out of bed and go looking for a nurse. So do you think he has the cognitive capacity to make the decision pertinent to the health and safety? Yes or no? Yes or no?
Difficult to say from the start because maybe because the patient excited or surprised, just answer that and forgot has amputated limb.
So what the scenario I'm telling you, do you think he has the capacity when he responds to the bed, said, well, I'm going to roll out of the bed. I know I don't have my legs, but I'm going to roll out of the bed and try to get to the nurse and go away from the fire. Does he have the capacity?
Yes.
Yes.
Yes, yes. Thank you. So what we're saying is having the diagnosis of dementia doesn't mean people do not have capacity to make decisions. However, someone asked the question and said, is there a standard method, right? So generally, people do perform mini mental status exams. It's already in the chart in different form and shape. Sometimes it is not. Now you can say that they lack the cognitive capacity for physical decision, health and well-being. But if the mini mental status is really poor or they are scoring really low on the standardized testing, then you could make sure to say that he lacks the cognitive. At the time of my assessment, I found Mr. Smith lacking the cognitive capacity of make decisions pertinent to his physical health and finances, right? Because he doesn't have those operations. He can do serial subtraction. He cannot keep his book. That's when you will be confident about the decision. Okay, so did I confuse you more or did it help clarify that?
Yeah, it's really helpful. Thank you for
Okay.
answering my question.
Thank you. Thank you. So now, key points. Cognitive capacity is different than competency. One is a legal term, other is a more expert or physician or medical medical tool and that lingo. So capacity requires few C's. Do I know what my choices are? Do I understand the consequences of, do I have the choices? Do I make those choices and know the consequences of those choices? And if I do, then I have the capacity, cognitive capacity at the time of your assessment. If I get done in 30 minutes and I overdose on Valium and Librium and have a couple of drinks, I may not have that capacity, right? So that's why at the time of assessment. Okay. Any more questions? Because I think you all ready to perform cognitive capacity in each other in your spare time.
I have a question. So regarding when a patient come, for example, for Medicaid or for anything, we want to do the mini mental test or any one test. So, and we know that this patient has a limited certain educations, and especially for math could be sometimes hard for people to remember, like subtract things, that right? Even if you have a good memory.
Right.
So in this case, what we, if we have, for example, illiterate patients and we can perform the many mental or any test, what do we do to give a report about the patient?
Right. So you write what you could do and what you couldn't do. Said he was agitated, was not able to complete the mini mental status testing. So it's So there are 2 points I'm trying to push through here. Number one, that
Mhm.
these tests, that minimal status and MOCA and all that, they are good to have. It should be done if possible.
Mhm.
However, they are not the basis of cognitive capacity decision alone. If you have it, great. But if you don't, it is not the decision making. Decision making capacity is about being able to identify a threat and then able to work towards safety and away from that threat through a logical reasoning and a reasonable decision, same decision making.
So, what it's mean is that as a physician in real life, it doesn't just depend on the test. It's mean on you as a physician, your observation for the patient reasoning, and making this logic.
Through interaction.
Okay.
Through interaction.
Okay.
Does that answer your question?
Yes. Yes.
So
Because
it's good to have testing.
Yes. Yes. I'm putting scenario in my mind. If someone
Good.
have limited.
You can perform this testing on your spouses and family members and say, what are you going to do when you are in the woods? And I think they will pass. Just kidding. All right. Thank you very much.
Thank you.
It's been great talking to you again. And thanks for the invite, Nader. That was nice.
Thank you, Raza. This is interesting. This is really helpful. Any other questions for Raza? So to simplify things, Raza, maybe you can correct me. Basically, we can look at differently. In renal failure, for instance, we can divide it into pre-renal, renal, or post-renal, right? So you have the blood coming to the kidney and then go out of the kidney. In cognitive and capacity evaluation, you want to give the patient some information. So input to the patient, and then the patient will process this information. And after this process, they will give you an output. So as Hiba mentioned, we can assess some part of this process with minimal statistics. We can get some numbers, but it's not like the renal function. It's not conclusive, like we say, this is step 1, step 2, step 3.
Right.
The number itself will help to some degree, but there are other components you want to assess. Some of the components, as Dr. Raza mentioned, is how you want to get the decision they arrived to, the process itself, the steps they took to go through that process of thinking. So you give them the options. So the input will be option 1, option 2, option 3, and then they will repeat this option for you. So option 1, I don't want to do it because, then they will give you reasoning. And then option 2, I don't want to do because, another different type of reasons they will mention. Then they will say, I'm choosing number 3, option 3, for instance. And this can be used, for example, with patient who going to surgery, for example. We want to understand if they know their option. One option is to go to surgery, one option is not to do surgery. And do they understand the consequences of these options? What happens if they take the surgery route, or what happens if they decline the surgery? And then how are they going to live with that? Something like that. So thank you so much, Raza. Did I make it clear?
It's absolutely correct. You're really saying that there is not one way of doing it. So you have to actually have the engine started, work, the logic sequence. And I like the way you could always give them option and ask why. So and I'm going to, in the closing, I say, so if there is a person who came in and he wants to go home because his dog is sick, but he just had a surgery 2 days ago, he still got a wound, but he wants to go home and say, I'm going to leave against medical advice. When you talk to him, he's saying that, yes, I understand that my wound can be bad. I have diabetes, I can die, but I need to go because my dog is sick and I can't handle that. And so his decision is, although based on an emotional reason, but he does have the capacity to make the decision because you know the consequences of the option that you're picking, right? Good.
I
Thank you.
have last question if there is time for this. Okay, go ahead.
Go ahead, go ahead.
Okay, so for in case we have a patient that he has some charges, like legal charges, and we think that there is certain there's something suspicious about his cognitive, and he's assuming that he doesn't remember, and malingering. So what we will do in to test for malingering in a cognitive test, is there like specific testing for this, especially in a legal way?
So at that point, when you're talking a legal issue, you would have your suspicion. And if you are not sure, you could just chart what you saw. The decision of malingering versus non-malingering is not our job. It would be taken up from, say, if it's a court case, goes to court, and there would be a forensic psychiatrist who will cross-examine him and examine him again. So from the legal standpoint, if you have concern, you share it with the staff, because a lot of time people will come to you and say, oh, look like he is malingering. And it happens a lot because they saw someone, they remind them of someone bad, and they think, oh God, these kind of people always do that. So people have biases, right? So that's why we don't want to jump on their bias and ride on it. We would just do what we think is right. And if you feel there is malingering, and you're confident, you can write that in the chart. Does it answer the question? So there are other steps. You are not finally responsible for him malingering in the legal system. That's not our job. We're not police, right?
Yeah. Oh yeah. Okay. Yeah.
Other question?
Excellent question. Any other questions? Thank you so much, Raza. This is
No
really
problem.
helpful, and we really appreciate your time and your information. Thanks for sharing and the education.
It's been a pleasure. Thank you again, and have a nice, wonderful day, whatever is left of it. Okay, take care.
Thank you. Bye-bye.
You're welcome.
Thank
Bye-bye.
you.
Have a good one. So, Raza and I, we play soccer sometimes outdoors, so when it's beautiful outside, so just to share with you. So far, we went through the capacity. Any questions, anything unclear, anything that you think you want to apply and you're not sure how to do it? If not, we can go to the next section of the meeting. So, anyone read the article that we shared? Sina?
Yes, that you mean the one with the dementia related to early menopause? Yeah, I did read it. Yeah.
Okay, so
Yeah, I read it.
excellent. So if you don't mind, every one of you, can you share just a couple of sentences of what you think, what's your input? What do you think with that article? Or maybe someone can summarize it in a couple of sentences, and another one can explain what, or they share what they think about.
So it's mentioned that actually from data collected in UK, I can't remember the exact number, but like thousands of women. So they did interpret the data, and they found the relationship between early menopause, like they mean like menopause before 40 years old, and dementia. Women with early menopause had risk of 1.3 of getting dementia compared to other like women who would like menopause in like 50 in the age of menopause, like in their 50s. They kind of relate that to the estrogen, as estrogen has antioxidant activity that will actually take the oxidation metabolites away from the body, and they think it can be related to aging. But the theory as well could be related to other things as well. So they are saying that taking estrogen, exercise, physical activity, diets, and like decreased smoking and alcohol could help. But actually the exact paper is not published yet. So to kind of find the exact statistical result, but it just gives us some idea about the relation between early menopause and dementia. Yeah.
Excellent. Thank you for the summary. Excellent. This is great. Anyone wants to share what do they think about that article?
Yeah, I can add to Dr. Sarah talk. Yeah, in the same article, they divided women to premature menopause before age 40 years, and early menopause between 40 to 45 years. So they found a strong link between low estrogen and increased risk of dementia, because there is a lot of estrogen receptors in the brain, mainly in the hippocampus area, where the memory and processing occur this area. Also, their estrogen plays a strong role in neurotransmitter within the brain, mainly dopamine, acetylcholine, and serotonin. And they suggest women with premenopause or premature menopause, they can take hormonal replacement therapy, and they can prevent that, Dr. Sarah said, by early exercise, cognitive training, and something like that. But at the same time, I found other articles published in PubMed. They talk about how we can prevent or treat early dementia on people they have estrogen deficiency, and the risk of there is a risk. There is no conclusive result in this issue, because they found estrogen replacement therapy increased the risk of if we give estrogen early in life, it could prevent the dementia in people with premenopause or early menopause. But if we give estrogen, later it will increase the risk of dementia. So many papers support this idea. So still the result, the link between low estrogen and dementia well established. But to treat that or to prevent that by giving hormone replacement therapy is still contradictory. So we need more clinical trials to prove that. So thank you for giving me the opportunity.
Excellent. Thank you so much, Sarah, and thank you, Abir. Anyone else want to share their?
I have just one point.
Go ahead.
Yeah, sure. That they mentioned that also in the article. The biological premenopause is more critical than the ones that happen by removal of the uterus or ovaries. Yeah, and when it is biological, the woman have to be aware that and educated about a lot of other organs rather than the brain will be in risk. Yeah, the heart, other organs, so she have to be careful. And yeah, one of the main points, as Abir and Sarah mentioned, it's very important to educate the woman about the importance of education, progressive education, and enhancement of the brain function will help to reduce the risk of dementia.
Sounds good. Thank you so much, Samah. This is excellent. Yeah, thanks, both, all of you, Abir, Sarah, and Samah. Anyone else wants to share any thoughts, any comments?
I didn't look into the literature, but from what Abir was saying, that there's an established relation between early menopause and dementia. So what about men then and dementia? So if low estrogen actually predispose females to dementia, so how is it with males and the relationship? I'm not sure whether this theory would be, I'm not sure, like, is it like female brain is different than the male brain? They like respond differently to hormones. It's interesting to know. Yeah.
Can I answer the question?
Yes, go ahead, please.
To my knowledge, but in the same articles I read that. So as general, dementia more common on female than male, because the female live longer than male, and it's age process as general. But the role of estrogen, the male, they have an estrogen by chemical reaction. The androgen in the adipose tissue, they convert it to estrogen, even it's minimum, but it's still there. But in female, so this process continues lifelong in male, but in female, it's linked with the ovulation and maturity of the ovary. So once the female reaches the menopause, the incidence become a difference between, because the male at the same age still has some estrogen, but in female it stops. This according to the same paper. So why they test giving female after menopause or decreasing estrogen hormone replacement therapy? Did this answer your question, or?
Thank you for, it actually gives me some idea. Yeah, maybe because of the female, like she has more estrogen during her early life, so the brain is kind of used to higher level of estrogen, but for the male, they are having like a low level, but it's steady through their lives. That's what you're saying. But for the female, they have both, like they have both the one from adipose tissue and the one from the ovary, but when they lose the estrogen, the high level of estrogen from the ovary, they still have the level from adipose tissue, but it's not as high as she used to have during her early age or before menopause. Maybe. Thank you for your answer. Yeah.
You are welcome. Yeah, but I think we have to read more articles. Yeah, it's still a testing topic. Yeah.
It's interesting. Thank you so much, both Sarah and Abir. Go ahead, Alvari.
Oh, yes, I think it is interesting paper, but what I have seen that I think with regarding to gender, male and female, I think that's what's kind of limit the study for generalizability, because like even they kind of define exactly the dose relationship depend on like increased amount of estrogen in female compared to male, but still I think they have to address other confounding factor, and specifically modification interaction. Maybe if you kind of address the age specifically, and interaction with age at the same with estrogen, so it's kind of like take the results away from the null hypothesis if we take an age as a variables in addition to estrogen. But I think in general it's kind of interesting paper, and I think yeah, we need to learn a lot about these issues. Thank you a lot.
Thank you so much, Dr. Alvari. Anyone else?
Yeah, I have one comment.
Sure, go ahead, Dr. Asad.
Yeah, it is very interesting paper, but I think we have to consider all the confounding factors in this study. So we have to put special attention on autoimmune disease and exercise, education level, and other factors that may affect this study. So you can't say that estrogen is the only factor that related to menopause, early menopause. So I think there is a lot of factors that should be addressed in this study. So just they concentrate on estrogen and the relation with estrogen and dementia and with this premature menopause. So, but I think the other factor, even the psychological factor, is we have to put in mind psychological factor, because if you regarding psychological factor in women is very essential, especially in this kind of disease like dementia. So if we put in mind that early menopause may affect the woman psychologically, and that may affect the brain. So I think it is very complicated. It is not like just estrogen and the brain function. So I think we have to put in our minds that all factors can affect, even exercise, education level, and as we know that everything, if you don't use it, you will lose it. So the brain, if you don't use it, you will lose it. So we have to know the level of education for this 153,000 cases, to with that in mind, and the other cofactors like family history. Sometimes dementia, you can say that it is high in some families. I don't know. That's
Thank
what
you. Yeah, thank you so much for your comment. And Hassan, go ahead, Dr. Hassan.
Thank you, Dr. Nader, Osama, and Wali. Maybe I come across this paragraph in a wrong way, but I believe in the study itself, it's mentioned that the study was adjusted. Am I wrong? Was adjusted for age and weight, and I think even the education, the income, cigarette. So maybe this study has covered that spot. I'm not sure whether I read it wrong. Thank you.
Yeah, you are right. Yeah, they adjusted for that.
Excellent. Thanks for raising the point, Hassan, and clarifying the point, Dr. Abir. Good. Anyone else wants to comment on the article that we shared? How about the video? Anyone wants to share their thoughts about the video? Is it a good video? Useful? Anyone looked at the video in that website? Yeah, go ahead.
Yeah, I think in the video there is no there's specific information regarding how Alzheimer's disease destroy our brain, and they said it's decreased the white matter or the cerebral cortex become shrink, and the ventricle become wider, and the specific area hippocampus affected the more, where the memory processing occur. So it's a short video, just this information.
Yeah, you're right. So some of these videos sometimes might be useful when you are in clinic, for instance. You want to explain things to patients and family, and the process of the Alzheimer or the dementia in general, what pathology could happen, what we do to image, for example, CT scan, MRI, these sort of things, and measure size of the specific organ involved in memory, something like that. Like when orthopedic wants to do surgery, usually they have their, let's say, knee surgery. They have the model for the knee with bones together, the tissues, and then they will explain we cannot do this, and then we will fix this, something like that. So sometimes short videos like this can be used for education and might be helpful. Thank you everyone. Any other comments about this two topics or one topic? Any comments, questions? If not, we can go to the next section. So I'm going to share my screen with you, and I'm going to talk about prognosis, and let's use the so basically, I'm going to share the story of this prognosis. So there are a couple of physicians in California where they sat together, and they came up with the idea that how can we look at the indices or the calculation for prognosis, let's say in a group of patients admitted to the hospital with heart failure. Can we figure out which one will die, which one will not? And in a group of patients with hypertension, certain things can put in a calculator where we check mark, and then we come up with a score, and then we say, oh, there is a high risk of this because of all these conditions, something like that. So they looked at the literature, and then they joined by different groups from from another group in San Francisco, and some group from Johns Hopkins joined them, and then from Beth Israel, Deaconess Medical Center in Boston. So all these 4 groups work together to review some articles regarding this prognosis or prognostic disease that used for older patients. This review was done in 2012. So at that time, the article was published in Clinical Review. So what they did, they looked at different indices published through 2011, since the beginning of collecting the data in the database Medline, Embase, Cochrane, and Google Scholar. So these are the 4 databases that they looked at, and they come up with different indices. The total was 16, and then they formulate their paper according to that, and they said some of them might be used, some of them might not be helpful, something like that. And then this is their website where you can go to prognosis and use their tools. So all these indices, they put them into a form of calculators. So here you can go to the types of calculators that they used, and can look at the list. So they look at the patients living in different settings. One of the settings, living in the community, and they looked at mortality for a certain duration. And then they looked at patients in nursing homes, and the last group is a group hospitalized. Some look at patients with advanced cancer, like palliative performance scale, so they can use this scale. So all this can be used as calculators for communicating when we are talking about patients' survival or death rate or risk of death within certain group of patients. So, for instance, I teach medical students and residents and fellows here in Lansing area. So when we go, I practice only in nursing homes. In the past, we used to have a consult at the hospital. But when we see patients with let's say, end stage condition, dementia or congestive heart failure or COPD. And then with this condition, we identify certain symptoms indicating that the patient is declining. So if there are two components, the indication or the diagnosis, and then the symptoms that indicate that the patient is declining, so we can apply the concept of trajectory or the concept of what's gonna happen, and then we can put it as far as the prognosis for this patient, and we can talk to the patient or talk to the family about what to expect in the next, let's say, 6 months, weeks or days. And this is used also for hospice when we refer patient to hospice for eligibility. They want to make sure they have a diagnosis with an end-stage condition or terminal illness, and then they want some type of prognostication to indicate that the patient will die within 6 months if the disease takes its course. And we look at this with symptoms indicating that the patient is declining or the condition is getting worse and worse. And to do that, we can use some of this data calculator. So basically, we can apply it. It has a percentage where patient will be in a high category for, let's say, death in certain groups, and some other in a lesser risk. You can use this for educating the patient as far as what they expect and what they can plan ahead. If they want to set their assets and talk to their families and make plans, then they will be in a good shape to do that, or the family can be involved earlier in the process. This is one way of using the e-prognosis website, where you can use calculators. But for you guys, I want to share with you, they have another option where they have communication part. So in that part, they have some videos as far as example of discussion at the end of life with patient with end stage conditions, or in general, let's say diabetes discussion or screening discussion. So these are some videos that I thought maybe you can look at and in your free time before you start residency, because you're gonna meet this situation where you will meet the patient or the family, and you're gonna discuss about what is going to happen from what we think, according to what we studied or what happened to other patients in the past. So we can say it's better for you to do this type of screening, or it's not good to do this type of screening, for instance. So these videos, I hope it will help you. So if you can look at this website, and hopefully you will benefit from it down the road. So in the next couple of months, before hopefully you get selected for a residence program, then you will practice with these videos, so you will be ready for your patients when you start residency. The article itself, it's done, as I said, in 2012. So there are more and more indices since then. So for us as fellows, one other point I can share with you, if someone is interested, is we can repeat the same study or same approach for 2022 or 2021 and look at the indices since then. So if there are more, we can add that to the literature, and then we can share it with this group in e-prognosis, or publish it as a paper, something like that. So this is one thing I want to share with you, and I want your input. If anyone have a question or any comments, please go ahead. I want to do the same approach they did for the study they did in 2012. So I looked at their way of doing things. So this is basically the same method we can apply. So instead of 2012, we can say 2022, and then we will look at the literature the same way. We will look at all this database used. We will use the same keywords that they use, and then we will select whichever tools that are mentioned in the literature applied to all the other 60 plus, and then see if the information we collect can be applied to a certain setting, like specific hospital, community nursing home setting. We can extract the data and look at the results, and then we can come with same or different conclusion, so that we can help other physician or healthcare provider in the future to use some similar tools in this area. Does it make sense for you guys? Or? Any questions, any comments?
Just a question, maybe I did not, I just missed the first part of your presentation, but is it like the e-prognosis come through the validation process as just a scoring system, for example, say for PE, or like what is called the score of P and DVT and all that? It's just like a scoring system for prognosis, as you mentioned.
Yes, so if you go to their website, you can look at. So I practice in nursing home, so I come to this and they ask about the patient in nursing home. Is this patient have dementia? Let's say yes, they have dementia. So there is an index done by Mitchell. And then this is the survival rate for 6 months. So here you will see there is some questions to calculate their risk in the next 6 months mortality, for instance. So you can answer all these questions and then you calculate. So basically, yeah, it's similar to
Wells score. I mean,
yes.
Prediction model.
Prediction model. Yeah, same way. So you can use it, and it's just helpful to be used in the future. Excellent. Any other questions or comments? So I'm gonna just switch to here, and I think Sulafa mentioned about the evaluation with cognitive training, or HIPAA mentioned mental state exam, let's say the scoring system. So there is an article, recent one, that looked at evaluation of the computerized cognitive training. So this way of training that can be used in patients with HIV. And it's a meta-analysis, and this was done actually 2 days ago, published in Infectious Disease. So from this title, this information I gave you, can you tell me any thoughts? Anyone? Or any question or any comments? So you are doing research fellowship and you're looking at this article. What do you think?
I didn't get the question well, honestly. When do
So looking at this
okay, evaluation of
article,
computerized cognitive training and cognitive
mm,
and daily function in patient living with HIV. So particularly here, our subject is the HIV patients.
so the subjects are, yes, yeah, go ahead.
And we want to examine the daily function in this. And basically what we want, the higher, what they call it, executive order, something like that. I don't know.
Yeah, so basically what they did is they identified patients with HIV and then they applied some training and they want to evaluate or monitor their cognitive function on a daily basis and then continue to see if this is helpful or not helpful in this group of patients. So it's an interesting concept of applying some way of, let's say, games or some interaction with patients or music, or it's just you want to motivate or enhance the cognitive ability of these patients with HIV and then see if that can maintain or improve or lessen the risk of losing some of the cognitive capacity there or ability. So go ahead.
So basically what you try, because they just the title, I didn't got what they want to say. So now from your explanation, so they giving a game to the HIV patients and they assess how their performance daily and see if that increasing their function, cognitive function. So that's the aim of the study. Wow, that's interesting.
Yeah. It is interesting, yeah. Anyone else? Thanks, Hilda.
I just wondering why HIV, if they include patients, they have cognitive impairment or something related to HIV, or because just infectious disease journal they want.
Excellent question. So we can go to the introduction and then see why they selected this HIV patients. Excellent question. Excellent. So anyone else wants to comment?
Just wondering whether is there, like, I know HIV patients, like whether their age, their like severity of their HIV or the length they're having HIV could be, I think this is a wide range, like just saying patients with HIV because they develop like the HIV dementia and all that lately after having HIV for long years. So.
Excellent point. Anyone else? Any other observation? So basically, it's done in a group of patients with HIV, and it's published, if you observe, it's in the article of the journal Infectious Disease. So they collected information about patients with HIV that are at risk for going through dementia related to HIV, and they published their article in infectious disease area because they focus on patients with HIV. If you want to apply the same concept in different group, let's say patients with heart disease, congestive heart failure, or coronary artery disease, or whatever, then your subset of patients or participants or subjects will guide you as far as when you want to apply to submit your manuscript for publication. So you will be limited by your group of patients in the area. So if we change patient with HIV to patient with heart condition, then we can apply to journals that look at the heart or publish papers in the heart. Or let's say patients with liver disease, then we can go to GI are journals that are interested in this area. So sometimes when you think about how you want to do your study, before you start, you think also what's your end game, where you want to submit your end product. So the end product here, talking about HIV, then the article, the journal that we should target will be infectious disease, something like that. Same concept when we are writing an abstract. So we will write the abstract. So we will be guided when we see certain patients with what organization that accept this type of abstracts. Like in geriatric, we have society, the American Geriatric Society. They are interested in certain parts, but in general, they want to have studies on older patients, 60 plus. So if we have anything to do with this group of patients, so we will have high chance when we submit our abstract to AGS. If we are doing some studies or our data are collected from nursing home residents, for instance, then when we finish our abstract, we can submit it to the American Medical Director Association, because this institute, this group or organization deals with patients in nursing home setting, something like that. So you think about what your end result is going to be published at, and then you can formulate your title so that it can match the interest of this journal or interest of the organization, the conference, the meeting that you want to submit your poster or abstract. Same way like Selma, if you are with us. So she and her team were working on elder abuse. So she submitted the abstract to an organization and they did not accept that abstract. So there could be many factors in the rejection for that abstract, but she did not limit herself to that group. She looked around and she found another interested organization in the area of older adult abuse or something to that effect. So she improved her abstract with her team and then submitted to that group and has been accepted, and she presented that. So sometimes you just look at what's the end game for your research project. Does it make sense for you guys? Any comments, any questions?
Yes.
Go ahead. Abir.
Dr. Alwali is raising his hand.
Dr. Alwali, go ahead. New question or previous?
Yes, actually, I'm kind of wondering regarding the study that like computerizing cognitive to just to a kind of intervention or exposure to, and then see the outcome in HIV patient. So I'm wondering just regarding the control. So I think when they choose HIV patient and they would apply these kind of measures, and then they will assess their outcome, which is difference in their daily function and cognitives. So the control would be like other like dementia patient, and they will apply the same measures, or they will find an HIV patient but without applying this measure. Not kind of just kind of wondering regarding this issue. So what they gonna do? I'm not kind of sure exactly. So which control group they will use? Yes, that's what.
Thank you so much for your question. So this is an interesting question also. So if you look at the their abstract again. So they looked at the patient with HIV, and so as some of you mentioned, there is an instance of dementia or some cognitive disorder related to that. Their objective was to examine the association between the domains involved and in this group of patients. So the data source is from, again, they looked at databases, so 4 of them, and then they collected what's in the database or the literature, what's there, and then they come up with this, like how many studies they found. So they are not interested in doing the studies themselves. It's like a meta-analysis. So they look at the literature and see how many studies done in this group, and then the total number of patients in identified, this, how many articles, and then they compare this. Does it make sense?
Yes, it is.
Thank you. Someone wants to ask? Is it Hiba? You want to comment? Or ask?
Yeah, in meta-analysis, do we need to, like, all the study need to be from this having the same structure? Like, for example, all of them need to be like cohort or RCT, or it could be randomly case control RCT cohort, because this is may different have some impact in the result, or doesn't matter?
So for this group, I think they wanted, okay, so to start with, you want to identify your keywords when you want to look at the literature. So when you get all these results, you may get RTC or whatever type of studies there. And then you can, what we call it, filter out. So if it's only RTCs that you want, then if your results come up with 24 articles, so you want only the RTCs, then you will only filter the total number and collect only the RTCs that you want to study. Does it make sense?
Yes. So they filter based on the study type or just on the keyword? Because I see here they reporting incidents. So is this apply for any other study? I don't know how to address it.
So
can I?
Go ahead.
Yeah. Sorry. So from my knowledge that like you usually include the same type of studies, like say if you're including clinical trials, you probably because you're probably like reporting association and correlation. So, and that you get it from clinical trial, like you have intervention. And if you are reporting like something that like observational from case control or whatever, you sometimes can mix like cohort or case control if they are reporting the same statistical findings. Say, you can't say if you're reporting correlation in this study, they need to use even the same statistical method. So you compare and you plot all the results and like getting them all together to find the end. So the end result. So you actually say one study found an incidence of like 1 in a million or whatever, and then other studies found another number of incidents. You actually find you get all the results and you get the average of all the results, either like say 2 people in a million, say for example, it's an incident, or if the correlation is like 1.3 and the other study is 1.4, the other one is 0.9, you actually calculating the whole result and getting the average of the 3 results. So, and then if you are putting clinical trials together during the systematic review methodology, you actually assessing the bias and all that. And through assessing the bias of those studies, it needs to be the same method of a study, like a clinical trial. You're comparing clinical trial and you are criticizing those trials about whether these results were accurate, whether they were going through the steps of doing clinical trials and all that. So most likely, if you're doing meta-analysis, basically, it needs to be the same methodology.
So we need to match in the exposure and outcome of interest. So in this case, could be because we're measuring incidence. This could be just we're looking for exposure and then we look for outcome for this all result together. That's what does it mean?
They are studying, like they are giving intervention like computerized stuff and measuring the effect of this. So it's a trial.
Mm-hmm.
It's a trial. It's a clinical trial. They are observing the effect of these computerized practices on their cognitive function. So they probably introduce this intervention and looking for the result into the patient, their cognitive function over time. Say, for example, I didn't look the study itself, but I'm just guessing. So, like, say, it might be they are using different computerized program in different trials included in the study.
But the structure,
yeah, and they are studying the same differences in their cognitive function. For example, I hope I answered your question. Thank you.
No, you answered. Actually, that's what I want to ask. Like in meta-analysis, do we match the study structure, or we just randomly select any study that's having the same outcome of interest or whatever? Okay, thank you, Dr. Naden. Thank you, Sarah.
Thank you so much, both Eva and Sarah. Excellent question, explanation. Thank you so much. Anyone else wants to ask? Anyone wants to add comments? Or
I think I comment, Dr. Nader, if you allow me.
Yes, please.
That's why maybe meta-analysis, I think that's question is really critical. That's maybe usually the methodology, or there is some methodological issue with the meta-analysis when you come to judge the efficacy of the treatment or the interventional, because it's very difficult to compare between two studies and to come up with some conclusion. I'm not quite sure, but maybe you could add some comment to that. Thank you.
So again, it depends on how you design your method. And in this, let's say, article, usually they have an exclusion and inclusion criteria. So when you have the list of articles that you will get from your search, you will apply this to a list of inclusion and exclusion, so that you want to, as much as you can, match them, whatever the final list that you will get. You want to get them as close as possible, as far as the comparison you want. As Sarah mentioned, you want to measure certain things. Is this certain measurement found on all your list of articles or the results or not? Because if, let's say, in 10 of the articles that you found, they did not use, let's say, for simplification, BMI as a measurement. They want to see how the BMI affect, let's say, cognitive function. So if out of the 24 studies that they found, 10 of them, they don't have BMI, but it's one of the inclusion criteria, then these 10 studies will not be used for this purpose. Does it make sense?
Yeah, thank you, Dr. Nader. Thank you.
Any other comments, any other questions?
Can I add something here?
Yes, please. Go ahead.
According to level of evidence, there's a hierarchy or pyramid, meta-analysis and systematic review on the top, and randomized control trial below them. And that's why, because on a randomized controlled trial, we do one trial in specific population, in specific area. But when we do a systematic review or meta-analysis, we collected multiple randomized controlled trial or different study design. So like big trial from Asia, from Europe, we collect all of that from America, Canada. So the evidence becomes stronger when we do meta-analysis and systematic review. Yeah, this one, it is called level of evidence. So, this is why meta-analysis is the base of evidence-based medicine, because it is collected data from, and when we collect data on a large sample size, definitely the bias and heterogeneity decreased dramatically. So this is why. And the question regarding we have to include a specific study design and meta-analysis, it depends on your study and research questions, because we can do a meta-analysis and include different study design like observational, clinical, and something like that. And according to my research question, I just decide to include just randomized controlled trial. And the big difference and the main difference between systematic review and meta-analysis, the numbers. When we include the statistics, definitely it's going to be a meta-analysis, not a systematic review. So this is the big difference between two of them. Thank you.
Thank you so much. Excellent point. Anyone else wants to share or any question? Yes, go ahead.
Yes, actually, Dr. Abir, and yes, I want to add Dr. Abir and Dr. Osman. Yes, actually, yes, meta-analysis and randomized. With randomized, still there's kind of an issue related to some ethical issues, and all the time there is sort of lack of generalizability of the randomized controlled trials. But with meta-analysis, is still it depends on the qualities of the study that you kind of analyze, because like if you kind of have a poor quality of studies, it may guide you in a different way, and your outcome or your results, it could be biased at the same time. That's what I want to add. Thank you.
Yeah, you are right. But as general, in a systematic review and meta-analysis, we do something called quality appraisal. So we have to include papers or study that has at least 70%. There is a specific tools for specific study design, and we have to exclude all biased and low quality papers. We can include moderate to high quality. So we assess the paper before we write our systematic review or meta-analysis.
Excellent. Thank you so much, Abir, for the clarification. I think this made it clear. Does it, Dr. Hassan? Excellent. Thank you so much, all of you. Anyone else wants to add or wants to ask questions?
Sorry, but I looked into Cochrane for systematic review method. So if you look in the chat, you can read what they have written about the issue we were discussing. Thank you.
Thank you so much, Sarah. Anything else? thanks for sharing the handbook as well. If no other comments, and then maybe you can go to the next agenda item for next meeting next Saturday. Anything you want to put in the agenda? Any suggestions? I know next week will be just a couple of days before the match, and I wish you all the best with the match. Share your good news when you get the good news. So I know many of you might be busy during the coming days and next week and the week after. So I suggest some items, and if anyone wants to add more, we can do that. Let me share what we have here for next week. So perhaps we can talk about a stroke and cerebrovascular disease, and then we can focus on some research projects. One more topic is so we can discuss this. Baba and Sumi said they are willing to share their experience in the past, and maybe they can add some of the information there. Any questions? Any comments? Yeah.
Is there a specific person who's going to present about a stroke next week?
So I think their team can decide which one. If Lena, I don't think she's present now, but if someone can reach her, see if she will be available to moderate. Otherwise, one of the team can do that, and same person or different person might go over the stroke presentation. If there is no one, I will be happy to do it, but it's gonna be just an opportunity for some of you to present. I know some might be busy with many things in the coming days, weeks, so I understand.
Yeah, so if no one actually, I can volunteer to do the stroke presentation. Okay. Yeah, can keep me busy during this week, actually.
So do you mind if I put your name here?
Definitely. Thank you, Dr. Nader.
So I think you will have access to the file there. It's supposed to be in the geriatric TGRF slides, I think. Just double check. Yeah. So if you go to the list here, go all the way to slide GRS slides, and it will be number 4 from or number 3 here. So the file will be there. So if you can download and edit, or if you want to look up some more information up to date, that would be great also.
Perfect. Thank you.
You're welcome. Thanks. Any other questions? Any other comments, suggestions? If not, then we will see you next week, and I wish you all the best. Hopefully we will hear good news the week after. Thank you everyone for your participation, and it was lovely to have you. I wish you all the best. Have a great day or night.
Thank you so much, Dr. Nader.
Thank you.
Thank you. Thank you, Dr. Nader.
Thank you.
Thank you, Dr. Nader.
Dr. Nader. Assalamu alaikum.
Thank you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir. Thank you, everyone.
Thank you so much.
Have a wonderful day.